All right, so here we're going to demonstrate anterior ring fixation using the CurvaFix device. We're going to approach the pubic symphysis, cross it, and dock our fixation in the contralateral superior pubic ramus above the obturator foramen on the far side, so we get good purchase. I always like to start with the cannulated awl. I didn't at first, but now that I've started using it, I really like it. It's very useful in helping get you an accurate starting point. And you really need to do 5 to 10 of these in a short period of time to get through the learning curve of using it just like any other instrumentation. If you use it once, go months before you use it again. You're just starting back at ground zero. So really buy into it, start to use it. Once you get through the learning curve, there's almost no corridor in the pelvis you won't be able to instrument. So the same exact incision we used for our posterior fixation is going to be for our anterior fixation. Know where your ASIS is so that when you come up on that abductor or gluteal pillar, you can feel it. And then we'll get our teardrop or obturator outlet view shot there. Shot. Wire. True. Shot. And let's check the inlet so you can zero out the rainbow. Perfect. So we're on our inlet. We're aiming right down the 50-yard line in your anterior corridor, and on the obturator outlet, we're doing the same. So I'll just go to a mallet. We'll tap this in, make sure that we're more than 35 millimeters into that corridor. Shot there. Great. So again, I'll always use the triple cannula for the opening reamer. Right there. And a lot of times the fascia is so tight here, it's enough to hold your cannula. So if you want to use the pins to pin it, you can pin it. I don't, I just let the tension of the fascia hold it. And then again here, you have the notches on your opening reamer. You want to seat it to the full depth. And make sure that you're on ream. Alrighty. Shot there? Great. And you do have to be careful when you're using the opening reamer, especially in fragility fractures or elderly patients who have high energy injuries. Most of their corridors are more vacuous than what you'd be used to if you're fixing high energy pelvis injuries. And even though the guide wire is where it is, it can still windshield wiper with your opening reamer. So always just be careful and make sure you're going in the trajectory of that wire and you don't toggle. Shot. And I always just get images to double check. Shot again. All right, great. So I like where we're heading. We'll continue. Shot there. And now I'm looking for those notches on the opening reamer to engage that outer table. Come to an inlet. All right. There we go. Shot there. Great. So our notches are right up against that outer table. At this point, everything's going to come out, and then we'll put in our soft tissue sleeve. And sometimes it's easier to find your opening portal naked as opposed to with the cannula in. Shot there. And we're in. Cool. Now we'll go to the steerable guide wire. Again, that's 2.0 millimeters in thickness. Shut. Alrighty, and then come to the obturator outlet. Most of the time I have my posterior guide wires in at this point because I'd like to fix the front, especially in lateral compression injuries. Want to get the anterior ring fixed before you compress in the back, because if you compress in the back first, you can internally rotate the hemipelvis. So I always like to get my, the fixation in the front to kickstand against that internal rotation moment before you compress in the back. So I'll have my guide wires in the back of the pelvis. And as you're getting your obturator outlets and your inlets and all of your different images in the anterior ring, it just gives you great visualization of the posterior pelvis just to confirm that your guide wires are exactly where you want them to be. So here we are aiming a bit posterior and a bit high, which is good because you want to kind of hug that cranial posterior cortex. Come around, shot there. Although not that much. Shot. Shot again. And you just bounce your way around the hard subchondral bone of the acetabulum. Shot again. Great. Shot there. And you can see it bounce caudally just off that anterior cortical bone. Perfect. So right now we're aiming a bit caudal and anterior. And as we come across that obturator ring, we'll swing it around and aim a bit cranial and posterior. Shot. Shot there. And once you come around that obturator foramen, you don't really need much of the obturator trajectory on your outlet projection. You can go straight to an outlet if you prefer. Makes it easier on the tech. So you can adjust your tip to get an idea of the direction you're in both planes in your mind's eye to help walk this thing across. Shot again. So right now I should be aiming posterior. Shot there. As we tap this across. So when you're crossing your symphysis, you don't want to be too anterior on the inlet, and you don't want to be too low on the outlet. And when you're choking up your T-handle ratchet, you don't want to leave big gaps of space between your soft tissue sleeve and your T-handle ratchet, because you could bend that 2.0 millimeter guide wire, especially as you're coming up on harder bone. Shot again. Shot there. So we're aiming a bit cranial and a bit posterior as we approach the symphysis. Shot there. Shot. Shot. There we go. So you really want to hit that symphyseal cortex at its midline or central point. And shot again. Okay, and go back to the inlet. Shot. And shot. All right, shot there. So we should be up against the symphyseal cortex. That's pretty anterior. So at this point, because I'm not getting exactly where I want to be to cross the symphysis, we'll ream up to this point. I'll take out the guide wire, put a little bit of bending on it so that I can get this exactly where I want it. Thank you, sir. Make sure you're on ream. And you'll notice that you hit pretty decent bone coming across the obturator foramen as that superior pubic ramus corridor narrows. Shot there. Great, so we're right there, so I'll take the obturator and we'll back this out. Alrighty, so at this point, I'll take the whole thing out and then we'll put a double bend on the guide wire. So I'll bend the guide wire first in the direction of the steerable tip, just about 4 or 5 millimeters off that ball. And when you do that, it's a pretty aggressive bend. That's not going to make it through the corridor of bone that you've reamed unless you put a backward bend on it a couple of finger breaths beyond where you bent it towards the steerable tip. So that looks good. So we look like we're pretty much straight in one plane and we have a nice double bend. So accentuate that tip, but then put a little bit of a back bend on it so that we can get it through that corridor. So I'll take the, actually put it in, and this will go in, I'll put this in naked without a soft tissue sleeve first, and then slide the sleeve over top. So the T-handle ratchet, which is here. Shot there. Shot. And come to the outlet. And the only reason I do it this way is sometimes it's hard to get the double bend guide wire through the soft tissue sleeve. Shot there. There we go. So now that we're in the corridor, I'll just wiggle it through to get it up to that symphysis. There we go. Shot. So we should be almost there. Shot again. Cool. Shot. All right, and then check an inlet. All right, great. So this double bend will allow us to come in much higher and posterior at that symphysis. Shot there. All right, great. So we're right at the midpoint on the inlet. Let's check the outlet. I'll bury the tip, then we'll put the soft tissue sleeve back over top to center us in our opening portal. And again, here you want to make sure you have very dedicated inlet and outlet views. And I really like how that looks. So we'll just make sure that we bury that tip. I'll put in that soft tissue sleeve. Alrighty. Shot again. Great. And again, a short distance. You don't want a big gap between your centering sleeve and your handle. All right. Shot. Sometimes it can be pretty challenging to get the guide wire across if people have very arthritic symphysis, especially in females that have given birth a lot. Their symphysis is going to be pretty arthritic. Trying to get it just across that bone can be a bit challenging, but the guide wire typically makes it across. So we'll go to the inlet, check that, make sure we like it. Awesome. So we're right at the 50-yard line on the inlet. And I like our position on the outlet. We're slightly aimed cranial, which is what you want. And then it's always good to keep your thumb or your index finger right on the guide wire in between your handle and your soft tissue sleeve so that you can get tactile feedback for any rotational movement so that you can make sure this is exactly where you want it to be. Shot. Shot. So we're across. Shot again. Good. Shot there. All right. So this typically happens where you just come out, you guide wire wants to come out the anterior cortex of the contralateral parasymphyseal bone. So we'll keep that image, save it, and go to an outlet. Okay, so I'm going to back that up, aim a little higher, or more cranial. Shot. Shot. There we go. So let's see if this helps. Shot. All right, so it's still probably wanting to come out that anterior cortex. So we'll back it up a little bit. Shot there. Okay, cool. Come to the inlet. I'll take one of those short threaded guide wires, load it up. All right, so right. Shot there. Okay, and then let me see this. So at this point, what we'll do is I'll make an incision right over the mons pubis. You have a knife? Right in the midline. Shot. Let's see a guide wire first. Shot. All right, come to the outlet. So I'm going to use this guide wire as a cortical blocking wire just to reestablish an anterior cortex because there is not much cortex. All right, shot again. All right, so that should be okay for an incision. So just a centimeter or two. So I want to get right at that parasymphyseal cortex. Shot again. Great, and come to the inlet. Shot. So I can feel myself engaging the steerable guide wire with this wire. I'm typically using a drill tip guide wire. So if you're using a drill tip guide wire, it's a little less aggressive. You can go on oscillate or reverse. Threaded guide wire, you could do the same thing. Just make sure you're on reverse. You don't want to go forward because you get less tactile feedback. So shot there. So you really just want to use this as a metal finger to push your steerable guide wire a bit more posterior. Shot. Shot. Shot there. I think we're on the wrong side. Shot there. Good. Come to the outlet. And a lot of times it'll take 2 or 3 guide wires to really give you that anterior buttress to allow your wire to stay within the contralateral corridor. All right, good. Shot. Shot. Shot there. Okay, come to the inlet. And before I even prep and drape, always make sure the patient has a Foley in there to decompress the bladder. So I'll get another image in line with the trajectory of the wires, just to double check their position. And good, so that one will engage. I just have to. So this gives you a really good idea of where your blocking wires are engaging your guide wire. Shot again. Shot there. Good. So I just want to make sure that we're aiming cranially with our tip of our steerable guide wire here. Shot. Excellent. So those blocking wires are doing the job. Shot. And at this point, I'll take the initially placed guide wire, reposition it, and we're just going to walk the steerable guide wire across the contralateral corridor. Shot. Shot. So I should be aiming right at that tip of the steerable guide wire because that's where I want to be to push it posteriorly. Perfect. Shot. All right, back to that 5-degree inlet. Okay, so I'm on the wrong side, so I just need to make the adjustment. All right. Great. So at this point, I'm going to ream to open up that symphysis a bit more, and that sometimes can help allow you to bounce off that far side. Yeah, there you go. So we'll go right to the 7/0 reamer. Shot. All righty. Shot. So that gives us a little more room, and now we can use our blocking wires to push us a bit more if needed. All right. You can take that. Alrighty. And there you go. Shot there. Shot. Shot there. Okay. All right. Shot. So now that we've reamed our path, opened up that contralateral parasymphyseal corridor a bit, I'm going to push the guide wire a little more with the blocking wires. And that ought to get the job done. Shot. Shot. Shot there. Shot. Okay, there we go. So now I'm just anterior to the guide wire and I'm pushing it a bit posterior, come to the outlet. Great, save that and then go to the inlet. Shot. Shot. Good. All right, come to the outlet. So at this point, we're across the contralateral parasymphyseal bone. We're about to enter the second zone of the contralateral anterior ring right above the obturator foramen. In some patients who have a very acute anterior ring, it's very difficult to get the guide wire up and across. Even if you can, you'll ream, and then it becomes very difficult to pass either the exchange tube, but the driving guide wire is not going to make it. If it's this much of a challenge to get your steerable guide wire up and across the contralateral zone 2, your driving guide wire likely won't either. So at this point, once I have a good crossing point, my steerable guide wire is across that parasymphyseal zone. I'm about to enter zone 2 of the contralateral side. You could stop here, ream, put in your exchange tube, put in your driving guide wire, and then follow with your implant. Shot there. So we're in a pretty decent spot there to do that. I'd like to be a little higher on the outlet, but some people's anatomy just doesn't allow for that. You can try adding another guide wire here to push it up. And in order to get across, we may have to do that. Shot. Shot there. So you can also get an outlet in the plane of the wire you placed. So just come up a little bit out of that. Great. Shot. Excellent. So that'll help redirect you in both planes. So go back to the 5-degree inlet. Shot. Okay. Well, we'll go across with the 7mm reamer, then we'll go with the exchange tube, place our driving guide wire, and then use the self-tapping, self-drilling head of the implant to get it across. I mean, for all intents and purposes, you could leave your implant buried in just across the symphysis, but the parasymphyseal bone is incredibly poor. So I prefer to get it up across into the narrow portion of the contralateral ramus, overlying the obturator foramen. Shot. All right, so we're there. Shot again. All right. Got that? Shot. Yeah, cool. So gets all the way across. And then the driving guide wire.
Ben's gone.
So let's see, a lot of times you have to put a bend on the driving guide wire shot, but here, one across, very nice. Sometimes I get caught up in the exchange tube. If that's the case, sometimes I will put a bit of a bend on the driving guide wire just to help encourage it across the symphysis. So at this point, a 180 is going to get you just into the opening of your contralateral zone 2 or across. If the pelvis is an abnormally large or small specimen, I'll measure, but if you put in a 180, you're safe here and you'll end that in that zone 2 contralateral ramus. No washers needed here because you're going up against the abductor pillar. All right. Shot. Should be coming up on the symphysis. Good. So right about here, shot there. I'm going to pull the driving guide wire back a little bit because I want the head not to go straight towards the anterior cortex of the contralateral side, but as the head hits those blocking wires, it should deflect it enough. Shot again. Shot. Great. So now, at this point, we'll pull this back into the implant fully. Shot there. Great. If you could just hold the back end of this as I steer it. Shot. Shot again. All right, so that's edging out the front. Shot again. And shot there. Okay, so here we're backed up enough, our head's across. You can do one of two things here. You can put in a key elevator and have your assistant steer this and turn it as you use your key elevator to keep it in that corridor. You can use a guide wire to kind of help use it as a finger to steer it in. Using the guide wire is a lot of fiddle factor. It could take a lot of time. Sometimes it's easier just to put a key elevator in there and just give it a bit of encouragement to get it across that contralateral supraobturator bone. Let's just get a shot and see how much play we have on this side. So if you could just push in a bit. So most key elevators will do, or even a cob. The key elevators, I like them a little better than a cob because they're a little flatter here. This one's a bit curved, but the flatter surface you get, the more control you have over it. So you can go right through the same incision that you've used for your cortical blocking wires. And you know you have a caudal border for where you want to go with your one wire. Shot there. So I gotta be a bit more. Shot. 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 All right, so send that forward a couple of turns. Shot. Shot. Okay. So once that threaded head engages the anterior cortex and starts to perforate, our elevator will push it back into the corridor. Awesome. So I really like how that looks. So you can start to advance. Shot. Shot there. All right. And advance. Good. Shot. Go. Shot. So I can feel the threaded head engaging as it goes across. I got this if you want to push and turn. Shot. So right now is the point where that threaded head is starting to breach, and I just want to make sure that our positioning is really good with the key elevator to push that across. Shot. Shot again. And again. Give it a turn or two. Shot. All right, good. Turn it. Shot there. All right, good. So once you've kind of just snuck that threaded tip into the contralateral corridor, it'll stay and it can continue to pass even if you haven't reamed. If you see on the CT scan that there's harder or more dense cancellous bone and the ramus across the obturator foramen on the other side, it may be a good idea to come in from the other side and ream up to where you're at now. Or if you know that beforehand, you can retrograde ream just to clear that path as if you were going to put in a retrograde screw before you cross the symphysis. But overwhelming majority of the time, the threaded head of the implant will find its way and stay in the corridor once you encourage it with the key elevator. If you want to pass your guide wire further at this point, you can advance it. Sometimes it'll go. Shot. But most of the time, it'll just follow itself. Shot there. Good. All right. Shot there. All right, so at this point, your threaded head is buried in the contralateral side, and you can lock it.